When doctors press their fingers against your wrist, your neck, or the inside of your elbow, do you actually know what they are searching for? Most people assume they are simply checking whether you are alive, counting beats in a quiet rhythmic ritual that confirms the heart is doing its job. But the reality is far more intricate than that. Those specific spots on your body, the ones every clinician learns to find with almost mechanical precision, are not random. They are not chosen for convenience. They are chosen because they are windows. Windows into the deepest mechanical truth of your circulatory system. Windows into pressure, flow, elasticity, rhythm, and even the silent warnings your body sends long before symptoms appear. And once you understand what is actually happening at those pulse points, you will never look at your own body the same way again. Let us begin with something simple. Your heart is a pump. A relentless mechanical engine that contracts roughly 60 to 100 times per minute every minute of your life without pause. Each contraction sends a wave of pressurized blood through a closed network of arteries, veins, and capillaries. The pressure generated by that contraction does not simply move blood forward in a steady stream the way water flows through a garden hose. It moves in pulses, surges. Each beat pushes a fresh column of oxygen-rich blood outward, and that column travels along the arterial walls, expanding them slightly as it passes. This expansion, this brief outward stretch of the artery, is what you feel when you press your finger against a pulse point. You are not feeling blood. You are feeling the wall of an artery responding to the pressure of your own heartbeat. And that distinction matters more than most people realize because it is the foundation of everything physicians can read from those points. Now here is where it becomes interesting. Not every part of your body is suitable for feeling that pulse. Most arteries lie buried deep beneath layers of muscle, fat, and connective tissue protected from injury and external pressure. But in certain very specific locations, arteries pass close to the surface of the skin, and just as importantly, they pass over a firm structure, usually a bone. This combination is essential. The artery must be near the skin so the pulse wave is detectable, and it must rest against something solid so that when you press down, the artery is gently compressed against that surface, allowing the pulse to be felt clearly. Without that bony backing, the artery would simply shift and slip beneath your fingers, and the pulse would vanish. So when a doctor reaches for your wrist, they are not picking a random spot. They are pressing the radial artery against the radius bone in your forearm. When they touch your neck, they are pressing the carotid artery against the deep muscles and vertebrae of the cervical spine. When they check the inside of your elbow, they are using the brachial artery resting against the humerus. Each pulse point is an anatomical accident of evolution turned into a clinical instrument. There are roughly 9 major pulse points on the human body, and each one tells a slightly different story. The temporal pulse, located just in front of the ear at the temple, gives information about blood flow to the head and is sometimes used in dental procedures or when assessing patients with facial trauma. The carotid pulse on either side of the neck is one of the strongest and most reliable in the body because the carotid arteries are large and carry blood directly from the heart toward the brain. This is why in emergencies, when a person collapses and there is doubt about whether the heart is still beating, responders are trained to check the carotid first. A weak or absent pulse here is a critical warning. The brachial pulse on the inner upper arm is the standard for measuring blood pressure and is also the primary pulse checked in infants because their necks are short and their wrists are too small for reliable readings. The radial pulse at the wrist is the most familiar to the public, the one we instinctively reach for when we want to know if someone is alive. The femoral pulse in the groin is enormous, powerful, and used in emergency vascular access procedures. The popliteal pulse behind the knee is more difficult to find and often signals problems when it is weak. The posterior tibial pulse behind the inner ankle and the dorsalis pedis pulse on the top of the foot are critical for assessing circulation to the lower extremities, especially in patients with diabetes or peripheral artery disease. And finally, the apical pulse, which is not a peripheral pulse at all, but the sound of the heart itself heard through a stethoscope placed over the chest, just below the left nipple at what is called the fifth intercostal space. Now ask yourself this. Why would a doctor ever need to check more than one pulse? If the heart is beating, then surely the pulse should be present everywhere, right? This is exactly the kind of assumption that makes pulse examination so quietly powerful as a diagnostic tool. Because the truth is, the pulse is not always equal everywhere. And when it is not, that inequality is one of the most important clues a physician can find. Imagine for a moment that a patient walks into a clinic complaining of pain in their left leg when they walk. The doctor checks the radial pulse in both wrists. Equal. Strong. They check the carotid. Strong. Then they kneel down and check the dorsalis pedis on the top of each foot. The right foot has a clear bounding pulse. The left foot has almost nothing. Just a faint flicker, barely detectable. In that moment, the physician has uncovered something profound. Somewhere between the heart and that left foot, the arterial highway is narrowed or partially blocked. The blood is not reaching the tissues with the same force on the left as on the right. This is the classic finding in peripheral artery disease, a condition where atherosclerotic plaque has built up inside the arteries, reducing their internal diameter and starving downstream tissues of oxygen. The patient may have no idea anything is wrong because the body is remarkable at compensating. But the pulse does not lie. The pulse reveals what the patient cannot feel. This same principle applies across the body. A weak or absent femoral pulse can suggest a blockage in the iliac arteries or even further upstream. A pulse that is strong on one carotid and weak on the other can indicate carotid artery stenosis, a condition that significantly raises the risk of stroke. A radial pulse that feels different in timing between the two wrists can hint at conditions affecting the aortic arch itself, the great vessel that arches up out of the heart and sends branches to the arms and brain. There is even a phenomenon called pulsus paradoxus, where the pulse becomes noticeably weaker during inhalation and stronger during exhalation. This subtle finding can point to cardiac tamponade, a life-threatening condition where fluid accumulates around the heart and prevents it from filling properly between beats. None of this is detectable to the patient. None of it shows up in casual self-examination. But to trained fingers placed in the right location at the right moment, these patterns are unmistakable. So, what is a physician actually evaluating when they touch a pulse point? There are several distinct qualities, each one offering a different layer of information. The first is rate. How many beats per minute? A normal resting adult pulse falls roughly between 60 and 100 beats per minute, though athletes often have rates in the 40s or 50s because their hearts are so efficient. A rate above 100 is called tachycardia and can indicate fever, dehydration, anxiety, blood loss, thyroid problems, heart rhythm disorders, or many other conditions. A rate below 60 is called bradycardia and may be normal in fit individuals, or it may suggest problems with the heart's electrical conduction system. The second quality is rhythm. Is the pulse regular, ticking like a metronome, or is it irregular, skipping, pausing, or beating erratically? An irregular pulse is one of the most common ways atrial fibrillation is first detected. Atrial fibrillation is a chaotic electrical disturbance in the upper chambers of the heart that causes the ventricles to contract at random intervals. Patients often have no idea they have it until a clinician notices the irregular rhythm at the wrist. And atrial fibrillation matters enormously because it dramatically increases the risk of stroke. A simple finger on a wrist has saved countless lives by catching this condition early. The third quality is amplitude or strength. Does the pulse feel full and bounding or thin and thready? A strong bounding pulse can indicate high stroke volume, meaning the heart is ejecting a large amount of blood with each beat, which can occur in conditions like hyperthyroidism, aortic regurgitation, or simply intense exercise. A weak, thready pulse suggests low stroke volume and may indicate shock, dehydration, heart failure, or severe blood loss. In emergency medicine, the quality of the pulse can be a life or death indicator. A patient whose radial pulse is barely palpable but whose carotid pulse is still strong is in a critical state because the body is shunting blood away from the periphery to preserve the brain and heart. This is shock in progress, and it demands immediate intervention. The fourth quality is the contour or shape of the pulse wave itself. With practice, and especially with specialized equipment, clinicians can detect whether the pulse rises sharply and falls quickly or rises slowly and feels sustained. A slow rising pulse can suggest aortic stenosis, where the aortic valve has become narrowed and the heart struggles to push blood through. A collapsing pulse, one that rises quickly and falls away, can suggest aortic regurgitation, where the valve fails to close properly and blood sloshes backward into the heart. These contour findings are subtle, but in skilled hands, they reveal the mechanical state of the heart valves themselves without any imaging required. There is also the matter of symmetry, which we have touched on already. A physician will often check pulses on both sides of the body simultaneously, not just to confirm presence, but to compare. The radial pulse on the right wrist should arrive at exactly the same time as the radial pulse on the left wrist. If there is a delay between them, even a fraction of a second, something is wrong somewhere along the path. A classic finding is radiofemoral delay, where the pulse at the wrist arrives noticeably before the pulse in the groin. In a young patient, this can be a sign of coarctation of the aorta, a congenital narrowing of the great vessel that has been silently stressing the heart for years. Without that simple comparison, the diagnosis might never be made until catastrophic symptoms appear. Now let us go deeper into the physics of what is actually happening at a pulse point, because this is where most explanations stop short. When the left ventricle of your heart contracts, it ejects roughly 70 milliliters of blood into the aorta in less than a third of a second. That sudden ejection creates a pressure wave that travels through the arterial tree at speeds far faster than the blood itself. The blood moves at perhaps 30 to 40 centimeters per second in the aorta. But the pressure wave, the actual pulse wave, travels at 5 to 10 meters per second, sometimes faster. This is why you feel a pulse at your ankle almost simultaneously with a pulse at your wrist, even though those locations are very different distances from the heart. The wave is racing through the elastic walls of the arteries, propagating through them like sound through a stretched rubber tube. The blood itself is far behind, and the speed of that wave is itself diagnostic. Stiffer arteries transmit the wave faster. Younger, more elastic arteries transmit it slower. This principle is the basis of pulse wave velocity measurement, a modern technique used to assess arterial stiffness and predict cardiovascular risk. The faster the wave travels, the stiffer the arteries, the higher the risk of heart attack and stroke. All from understanding what a pulse really is. The arterial wall itself is a marvel of biological engineering. It is made of 3 layers. The innermost layer, called the intima, is a single sheet of endothelial cells that line the inside of the vessel and form a smooth barrier between the blood and the arterial wall. The middle layer, called the media, is the thickest and most important for pulse generation. It is composed of smooth muscle cells and elastic fibers arranged in concentric rings. This layer is what allows the artery to expand when the pressure wave arrives and recoil afterward. The outer layer, called the adventitia, is a tough fibrous sheath that anchors the artery to surrounding tissues and prevents it from overstretching. When you feel a pulse, you are essentially feeling the elastic recoil of the media doing its job. The artery briefly inflates, absorbs the energy of the cardiac contraction, and then springs back, releasing that stored energy and helping to push the blood forward during the relaxation phase between heartbeats. This is why the arterial system is sometimes called the second heart. Without the elastic recoil of the arteries, blood flow would be entirely intermittent, stopping completely between beats. Instead, the recoil maintains a continuous flow, ensuring that organs like the brain and kidneys receive a steady supply even during diastole, the resting phase of the heart cycle. As people age, this elasticity diminishes. The elastic fibers in the arterial media gradually fragment and are replaced by less compliant collagen. The arteries become stiffer. They no longer expand and recoil with the same vigor. This is why blood pressure tends to rise with age, particularly the systolic number, the upper number, which represents peak arterial pressure during heart contraction. Stiffer arteries cannot absorb the pressure wave as effectively, so the wave hits with greater force and bounces back faster, contributing to higher pressures and increased cardiac workload. A skilled clinician feeling a pulse can often estimate the approximate vascular age of a patient just by the quality of what they feel. A young pulse feels supple, slightly springy with a clean rise and fall. An older or pathologically stiff pulse feels harder, more rigid, almost like feeling a tense cord. None of this requires a single piece of technology. It requires only fingers, patience, and decades of trained perception. Consider now what happens during specific medical scenarios. During a routine physical examination, a doctor checking your radial pulse for 30 seconds is gathering an extraordinary amount of information in a very compressed time window. They are noting your heart rate, confirming whether the rhythm is regular, sensing the strength of each beat, comparing it to what they have felt in thousands of other patients, and quietly screening for atrial fibrillation, peripheral artery disease, aortic disease, and even early signs of heart failure. They are doing all of this with nothing more than 2 fingers. In emergency settings, the same skill becomes even more critical. When a paramedic arrives at the scene of a car accident and cannot find a radial pulse, but can find a carotid pulse, they immediately know that the patient's systolic blood pressure has dropped significantly, possibly to dangerously low levels. There are old field guidelines that suggest if a radial pulse is palpable, systolic pressure is probably at least 80 millimeters of mercury. If only a femoral pulse is present, pressure may be around 70. If only a carotid is present, pressure may be 60 or below. While these numbers are not exact and modern medicine relies on more precise measurements, the underlying principle is real. The body shuts down peripheral circulation first to preserve the central organs. The pulse points become a map of how much circulatory reserve remains. In surgery, the radial pulse takes on yet another role. During many operations, a thin catheter is inserted into the radial artery to allow continuous monitoring of arterial blood pressure beat by beat. This is called an arterial line, and it provides the surgical team with real-time information far more accurate than a standard blood pressure cuff, which can only measure intermittently. The radial artery is chosen specifically because it is superficial accessible and because the hand has a backup blood supply through the ulnar artery on the other side of the wrist. Before placing the line, the team performs the Allen test, compressing both arteries and watching how quickly color returns to the hand when the ulnar artery is released. This confirms that, even if the radial artery were to be temporarily compromised, the hand would still receive adequate blood flow. The pulse point in this case becomes both a window for observation and a portal for intervention. In cardiology, specialized devices have been developed to extract even more information from the pulse than human fingers can detect. A device called a tonometer can be placed over a pulse point and record the precise shape of the pressure wave with extraordinary detail. This recording, called a pulse wave analysis, can reveal hidden information about central aortic pressure, which is often quite different from the pressure measured at the arm. The pressure inside the aorta near the heart is what truly matters for cardiac workload and risk of organ damage, but it is impossible to measure directly without invasive procedures. By analyzing the shape of the peripheral pulse wave and applying mathematical transformations, clinicians can estimate central pressure non-invasively. This has profound implications for treating hypertension because 2 patients with identical arm blood pressure readings can have very different central pressures and therefore very different actual cardiovascular risks. The pulse seen through this lens becomes a Rosetta Stone for translating peripheral measurements into central truths. There is something almost philosophical about the pulse points when you consider them deeply. They are places where the inside of the body briefly becomes accessible to the outside. The arterial system is otherwise sealed away, hidden behind skin, muscle, and bone. But at these specific anatomical locations, the boundary between internal and external becomes almost permeable. A finger pressed against a wrist is, in a sense, reaching across that boundary, touching the moving blood column itself, separated only by a few millimeters of arterial wall and skin. This is why pulse examination has been part of medicine for thousands of years across virtually every culture that ever developed a healing tradition. Ancient Egyptian physicians wrote about the pulse over 4,000 years ago. Traditional Chinese medicine developed an extraordinarily sophisticated system of pulse diagnosis that recognizes dozens of distinct pulse qualities and uses them to assess the state of internal organs and energetic systems. Ayurvedic medicine in India has its own equally detailed pulse tradition. Greek and Roman physicians from Galen onward placed enormous diagnostic weight on the pulse. Long before stethoscopes, electrocardiograms, or ultrasound, the pulse was the primary means by which a healer could perceive the inner workings of the body. And while modern medicine has added vastly more powerful tools, the pulse remains foundational because it is immediate, accessible, and free. Let us turn now to something most people never think about. The pulse you feel is not just a single wave. It is actually a composite of multiple waves layered on top of each other. When the heart contracts, it sends out a forward traveling pressure wave. That wave races down the arterial tree, but at every branch point and at the small arterioles deep in the tissues, some of the wave reflects back toward the heart. The pulse you feel at any peripheral location is the sum of the forward wave and these reflected backward waves arriving at the same time. In young people with elastic arteries, the reflected waves arrive late after the heart has finished its contraction, so they arrive during diastole, the resting phase. This is actually beneficial because the reflected waves boost the pressure during diastole, which helps perfuse the coronary arteries that supply the heart muscle itself. The heart's own blood supply happens primarily during diastole because during contraction the muscle squeezes its own coronary vessels closed. So a young, healthy arterial system actually uses reflected pressure waves to feed the heart between beats. In older or stiffer arterial systems, the wave travels too fast and the reflections arrive earlier, overlapping with the forward contraction wave. This creates higher peak pressures during systole, increasing cardiac workload and reducing the diastolic pressure boost that nourishes the heart. The arteries, in essence, stop helping the heart and start working against it. All of this is encoded in the shape of the pulse wave at any pulse point if you have the tools to read it. There is also the question of why certain pulse points have become more clinically important than others over time. The radial pulse at the wrist became dominant in Western medicine partly because of social convention. In Victorian and earlier eras, it was considered improper for a male physician to expose a female patient's chest or neck for examination in the absence of strong clinical justification. The wrist, however, was always accessible without violating social norms. Patients could remain fully clothed and the physician could still gather extensive diagnostic information. This historical accident shaped the pulse examination traditions that persist today. The carotid pulse is more powerful and arguably more informative, but it requires touching the neck, which carries different social and even physiological implications. Pressing too firmly on the carotid artery can stimulate the carotid sinus, a cluster of pressure-sensitive nerve endings that can trigger a reflex slowing of the heart rate. In sensitive individuals, this reflex can be strong enough to cause fainting or even cardiac arrhythmias. So the carotid pulse, despite its diagnostic richness, is treated with more caution than the radial. The femoral pulse, though even stronger and more reliable in critically ill patients, is awkward to access in routine examination because of its location in the groin. So the radial wins by default for most everyday clinical encounters. Now consider what specific changes in pulse character mean in different contexts. A water hammer pulse, also called Corrigan's pulse, is a strong, rapidly rising and rapidly falling pulse that feels almost like a sudden slap against the fingers. It is classically associated with aortic regurgitation, a leak in the aortic valve that allows blood to flow backward into the heart between beats. The forward stroke is exaggerated because the heart compensates by ejecting more blood per beat, but the pressure collapses quickly because the blood drains backward. A pulsus parvis et tardus is the opposite, a small, slow, weak pulse that rises gradually and feels almost lazy. This is the signature of severe aortic stenosis, where the narrowed valve obstructs forward flow. A pulsus alternans is a pulse where strong beats alternate with weak beats in a regular pattern. This can indicate severe left ventricular dysfunction, the heart muscle so weakened that it cannot generate consistent stroke volumes. A pulsus bigeminis is a pulse where every normal beat is followed quickly by a premature beat, creating a coupled pattern often felt as an irregularity. This usually reflects an electrical disturbance in the heart with frequent premature ventricular contractions. Each of these named patterns is a recognizable syndrome encoded in the rhythm and force of the arterial wave. None of them require any technology to detect. They require only training and the discipline to actually feel rather than rush through examination. In the context of trauma, the pulse becomes even more vital. A patient with a severe arm injury might have a strong radial pulse on the uninjured side and a weak or absent one on the injured side, suggesting damage to the brachial artery somewhere along its course. This is a surgical emergency because limb ischemia, loss of blood flow, can cause tissue death within hours. In leg injuries, especially around the knee, the popliteal pulse is checked obsessively because injuries to the popliteal artery from knee dislocations can lead to amputation if not detected and repaired quickly. Even subtle differences in pulse strength compared to the opposite side can be the only clue that a major vessel has been damaged. Modern hospitals have ultrasound and CT angiography, but in the field, in austere environments, and in initial examination, the fingertips remain the first line of vascular assessment. There is another dimension to the pulse points that often goes unmentioned in standard medical education. The autonomic nervous system, the part of your nervous system that controls automatic functions, has profound influence over pulse character. When you are calm and relaxed, the parasympathetic branch dominates and the heart rate slows. When you are stressed, afraid, or exerting yourself, the sympathetic branch dominates and the heart accelerates and contracts more forcefully. Skilled clinicians can sometimes sense the autonomic state of a patient through the pulse alone. A pulse that races rapidly even at rest in a patient who appears outwardly calm can suggest underlying anxiety or hidden pathology, like hyperthyroidism. A pulse that varies noticeably with breathing speeding up during inhalation and slowing during exhalation is called sinus arrhythmia and is actually a sign of a healthy responsive autonomic system. The loss of this variability, the pulse becoming too regular, too metronomic, is paradoxically a sign of autonomic dysfunction and is associated with worse outcomes in heart failure, diabetes, and other chronic conditions. Heart rate variability has emerged as an important marker of overall cardiovascular and even neurological health. And it is detectable in basic form simply by paying close attention to a pulse over time. Modern wearable technology has begun to democratize pulse monitoring in ways that would have astonished physicians of even a generation ago. Smartwatches and fitness trackers use optical sensors that shine light through the skin at the wrist and measure the subtle changes in light absorption caused by the pulsing arterial blood. This technique, called photoplethysmography, essentially detects the same pulse that human fingers have detected for millennia, but does so continuously and with remarkable precision. These devices can now reliably detect atrial fibrillation, flag abnormal heart rates, and even estimate blood oxygen saturation. They have caught countless cases of previously unknown atrial fibrillation in people who had no symptoms and would never have sought medical evaluation otherwise. The radial pulse point has effectively been instrumented in real time and made available to anyone wearing a watch. But the underlying signal remains the same one that physicians have read with their fingers for thousands of years. Despite all this technology, there are subtleties that machines still struggle to capture. The textural quality of an artery beneath the fingers, the way it feels supple or rigid, the precise shape of the pulse contour, the way the rhythm responds to breathing, posture, and emotional state, these remain in the domain of skilled human examination. Medical education in many countries has unfortunately de-emphasized physical examination skills in recent decades, favoring imaging and laboratory testing. Yet experienced clinicians repeatedly demonstrate that the careful pulse examination performed at the bedside continues to yield findings that machines miss or take much longer to identify. There is a reason that the most respected diagnosticians often spend extra time at the patient's wrist or carotid. They're reading information that no scan can replace. So the next time you place your fingers against your own wrist or feel the throb in your neck after climbing stairs, pause for a moment and consider what you are actually sensing. You are touching the rhythmic output of a 4-chambered muscular pump that has beat without rest since before you were born. You are feeling pressure waves traveling through elastic tubes at meters per second. You are perceiving the convergence of forward and reflected waves shaped by the geometry and stiffness of your entire arterial tree. You are sensing the moment-by-moment balance between the sympathetic and parasympathetic branches of your nervous system. You are detecting in some small way the integrity of your heart valves, the elasticity of your blood vessels, and the responsiveness of your circulation to the demands of life. All of this in a simple throb beneath your fingertips. The pulse points are not just convenient places to count beats. They are diagnostic windows. They are pressure gauges. They are clues to disease that has not yet declared itself. They are records of the long, slow process of vascular aging. They are the most ancient and yet still one of the most informative tools in medicine. When a physician's fingers settle over the radial artery and pause there in concentrated stillness, something profound is happening. A practiced perception is reaching across the boundary between outside and inside and listening to what the body is saying about itself. The body is always speaking through these channels. Most people simply never learn to hear it. What makes this even more remarkable is how the body has been engineered through millions of years of evolution to make this kind of monitoring possible at all. There is no biological reason that arteries needed to surface near bone at exactly the locations where human fingers can comfortably reach. It is a coincidence of anatomy that turned out to be one of the most important coincidences in medical history. The wrist, the neck, the elbow, the groin, the ankle, the foot. Each one a place where the deep mechanical truth of the cardiovascular system rises briefly close to the surface and offers itself for inspection. And every culture, every healing tradition, every medical school in human history has independently discovered and made use of these locations because the information they offer is too valuable to ignore. Now think about what your pulse is telling you right now as you read these words. Place 2 fingers on the inside of your opposite wrist. Press gently. Find that small, steady throb. Feel the rate. Feel the rhythm. Feel the strength. That is your circulatory system reporting in real time. Every beat is a complete cycle of the heart filling, contracting, ejecting, and resting. Every beat is sending fresh oxygen to your brain, to your muscles, to every cell in your body. Every beat is also wearing on your arteries, adding microscopic increments to the long, slow process of vascular aging that happens to all of us. The pulse is both life and a clock. It is both reassurance that the system works and a quiet reminder of finitude. And it is sitting there at your wrist, completely accessible whenever you choose to attend to it. Pulse points reveal something else that is often overlooked. They demonstrate just how interconnected the entire cardiovascular system truly is. A blockage in one place affects pulses everywhere downstream. A weak heart produces weak pulses throughout the body. A leaky valve creates characteristic pulse patterns at every measurable location. Stiffening of the arteries changes pulse character globally. The body is not a collection of isolated parts. It is a single integrated system where the state of any component is reflected in measurable ways across many other components. The pulse is one of the clearest expressions of this truth. You cannot have a hidden cardiovascular problem that the pulse does not in some way reveal if you look carefully enough at enough pulse points with enough sensitivity. The information is always there waiting to be read. There is one final layer to this story that deserves attention. The pulse is one of the very few biological signals that you can monitor in yourself without any equipment or training. You do not need a doctor to take your pulse. You do not need a device. You need only your own fingers and a few moments of stillness. This makes pulse self-awareness one of the most empowering forms of body knowledge available. People who learn to take their own pulse, who notice when it is unusually fast or slow or irregular, often catch problems earlier and seek care sooner than people who never pay attention. A simple habit of placing your fingers on your wrist during quiet moments and noticing what you feel can over time give you a baseline understanding of your own normal. And from that baseline, deviations become noticeable. A new persistent irregularity. A resting rate that has crept upward over months. A pulse that suddenly feels weaker or stronger than usual. These observations matter. They are the same observations that physicians make for their patients, but performed by you for yourself. The pulse points in your body are not decorative details of anatomy. They are not random spots where blood happens to come close to the skin. They are the most accessible monitoring stations of the most essential system in your body, the system that determines whether oxygen reaches every cell, every tissue, every organ. They are where mechanical engineering meets biology, where pressure waves meet elastic vessels, where electrical impulses translated through cardiac muscle become felt sensations against fingertips. They are where ancient medicine and modern medicine meet on common ground. They are where machines and trained human perception both come to read the same fundamental signal. And they're always there, always available, always speaking. The only question is whether anyone is listening. So the next time someone places their fingers against your wrist or your neck and pauses with that particular quality of focused attention, you will know that they are not just confirming you are alive. They are reading a message that has traveled from the deepest chamber of your heart through the major vessels of your body at meters per second, carrying information about pressure and rhythm and elasticity and electrical conduction and autonomic balance and structural integrity, all encoded in the simple throb against their fingertips. They are practicing one of the oldest and most enduring arts in medicine. And now you know what they are actually doing. You know what those pulse points in your body are really for. They are not just for taking your heart rate. They are for revealing everything your circulatory system has to say about itself in any given moment. They are biological windows that have been there all along waiting for you to understand them. And now you do.